Well, I thank the gentleman, my colleague and fellow classmate, Dr. Rowe from Tennessee. And what I thought I would do is take just a moment and to discuss the historical aspect of Medicare and how we got to where we are today. I began medical school only 7 years after Medicare began. In fact, my colleague, Dr. Rowe, I think you're probably of similar age and station in life, and also Dr. Gingrey, who is here. Some of us may even remember before that. But I watched Medicare grow, and the promise to physicians and patients at that time is government, if this is passed, will not mess with anything. It'll be all between doctors and patients. However, by the time we got to the 80s, we found that couldn't be true. The costs were exploding far beyond inflation. And so the government, Congress, in fact, began to go through a number of calisthenics in order to make it work. One was RBRVS, which was a formula by which doctors would get paid rather than what their costs were. Then DRGs, diagnosis-related groups, to tell hospitals exactly what they're going to be paid regardless of their costs. Then CLIA. And then finally SGR, sustained growth rate, which we're struggling with now. And it basically means that if we miss budget targets, doctors get across-the-board cut, which would be up to 25–30% today. And of course, Congress keeps kicking the can down the road because Congress knows that if we were to actually implement the cuts that are required by law, that physicians would stop taking Medicare patients and we'd have a serious problem. So, if we fast forward to today, why is it that we can't control the cost of Medicare? And I just have to bring it down to the bottom line here. You control health care costs from one of two methods. One is a market-based, patient-centered method in which the patient is in the driver's seat, working in partnership with his or her health care provider, making the decisions, but also having a responsibility to control cost, which means they have skin in the game, which means through health savings accounts and things of that sort, they have an investment in controlling costs for them, and therefore they control costs for the rest of the system. Fraud, waste, and abuse is taken care of by the user, the consumer in that case, making this, in fact, the patient to be a savvy consumer. On the other hand, you've got to command and control, top to bottom, which is what Obamacare is. And the only way that you can control cost, Mr. Speaker, by doing that is to use a system like IPAB, this Independent Payment Advisory Board, 15 appointed officials who have absolutely no accountability to anyone. They're unelected and unknown for the most part. And if you have a problem with their decision, there's nobody to go to. No one is going to answer the phone. And so what does this relate to ultimately? Well, we get inkling of where we're going with this through funds going into this comparative effectiveness board, where studies will be determined to see how effective various treatments are and for whom. And this comes down to what is already implemented in Great Britain, NICE, which stands for the National Institute of Clinical Excellence. For a lot of people, it's not so nice. So how does it work? It goes like this. There's a certain number of procedures, diagnostic or treatment-wise, and there's so much money that can be spent on those. And then there's the needs, the people who actually need these. And so a determination is made based on a graph, if you will, or a matrix, whether or not someone's value to society, value of their life. In fact, they actually have a numerical value each year for what one's life is worth. And they go to this matrix and they determine in Great Britain whether or not it's worth that investment for them. So that may mean hip replacement, it may mean renal dialysis, or it may mean that your cancer doesn't get treated. In fact, if you look at the statistics, the comparative statistics between survival rates of prostate and breast cancer, two of the main cancers we deal with in this country, against Canada, which also has socialized medicine, in Great Britain, there's absolutely no comparison. The death rates are much higher in those countries. So I would submit to you, Mr. Speaker, today that if we continue down the Obamacare road, the implementation of IPAB, which is controversial even among the left of the left and very concerning for everyone, I think this is sort of the last shoe to drop when it comes to the creating of a government-run, socialized health care system in which bureaucrats will be making decisions about your individual life rather than you and your physician. And so we very much want to repeal Obamacare, but even if for some reason we can't, or until we do that, we desperately want to get rid of this IPAB, which we view to be toxic for our healthcare system and our culture in general. So with that, I want to thank the gentleman for having this discussion tonight, and I look forward to many more, and I yield back to